here we are again with plenty of news from the website prostatewarriors.com.
Yeah, it is really good to be back. And honestly, looking at the sheer volume of research we have to get through today, saying plenty of news feels like a bit of an understatement.
I mean, I think you're right. Usually when we sit down and do these deep dives, we're sifting through a lot of noise to find a few clear signals.
Right.
Maybe one good trial, a few minor updates.
Right.
But today feels different. The stack just feels heavy.
Heavy is the right word, but, heavy in a good way. It is heavy on hard science and consequently heavy on hope.
Yeah, absolutely.
We are looking at a landscape right now where precision medicine isn't just some marketing buzzword on a clinic brochure anymore.
It's actually showing up in the survival curves.
Significantly. I mean, we are seeing data where precision is resulting in massive survival extensions. We're talking years, not months.
Wow.
And in some cases, complete responses where the cancer just completely vanishes from the scans.
Which is the dream scenario for anyone listening to this. But we know hope is not a strategy, right? So the mission for this deep dive is to look at the nuts and bolts of how researchers are actually rewriting the playbook for metastatic castration-resistant prostate cancer.
Or mCRPC, exactly.
Right. And the theme emerging from all these papers today is outsmarting the resistance. Because that is the fundamental problem you face, isn't it? The cancer resists. It adapts.
It learns. It is an evolutionary survivor, and it's completely relentless.
Yeah.
So we are going to look at 3 distinct battlegrounds today. First, how we can use the tumor's own genetic mutations against it. Second, how we can turn its defense mechanisms into actual targets.
And finally, and I think this one is really fascinating, how we can use your own muscle mass as a biological crystal ball for survival.
That one is going to be incredibly actionable for you listening right now.
I really want to get to that muscle mass study because it puts some control right back in your hands. But let's stick to our roadmap. We're kicking off with the clinical trials first.
Right, the big pharmaceutical wins.
Exactly, the drug combinations. Then we move to the Star Wars section, the radiation and making tumors glow. Then the smart bombs of immunotherapy, and finally, that body composition and evolution research.
There is a lot to unpack.
So let's get right into it. The heavy hitter, the BRCAAway trial. This is a phase 2 study, and I have to say, the headline number here made me stop and reread the abstract.
I did the exact same thing.
We are talking about a median survival extension that pushes past the 5-year mark.
It is a stunning figure. In the world of metastatic prostate cancer, especially when we are talking about castration-resistant disease, we usually celebrate gains of, 4 or 5 months.
Right.
To understand why this result is so completely different, we have to look at who this trial is actually for. Because this isn't for everyone.
Right, this is precision medicine at work.
Yeah.
So who is the exact target?
This is for men with mCRPC who have specific genetic markers, what we call HRRM, or homologous recombination repair mutations.
Okay, let's pause and clarify that for a second. HRRM.
Think of your DNA as a set of blueprints. Sometimes those blueprints get torn during normal cell division. HRR is the crew that takes them back together.
Okay.
If you have a mutation in genes like BRCA1, BRCA2, or ATM, that repair crew is faulty. The DNA just can't fix itself properly.
So these men have a broken repair kit, basically. Historically, how have we treated them?
Well, we usually go one of 2 ways. We use standard hormone therapy, like abiraterone, to starve the cancer of fuel. Or, more recently, we use PRP inhibitors, like olaparib.
And PRP is like a backup repair crew, right?
Exactly. PRP is the backup. So if you block PRP in a cancer cell that already has a broken primary repair crew...
The cell can't fix itself at all and it dies.
Precisely. That's called synthetic lethality.
Yeah.
But the debate has always been, do we use these drugs one at a time sequentially, or do we throw the kitchen sink at the cancer and use them both at once?
The shock and awe approach versus the save some ammo for later approach.
That is exactly the debate. So the BRCAAway trial compared 3 arms. One group got abiraterone alone, one got olaparib alone.
And the third got the combination. And this is where the data just screams. It's not a subtle difference at all.
No, the curves separate early and they stay separated.
If you look at the median overall survival, for the group that just took abiraterone, it was 28 months. For the group that just took olaparib, 37 months.
Which are very respectable numbers for this stage of disease.
Sure, absolutely.
Yeah.
But the combination group, 68 months.
68 months. That is a median survival of over 5.5 years.
Compared to just over 2 years for the standard hormonal treatment. That is more than double the survival time.
It really is paradigm shifting.
But I have to ask the obvious question here. You're combining two powerful drugs. Usually when we add drugs, we add toxicity. Is the extra time worth it if your quality of life absolutely tanks?
That is the crucial question. And surprisingly, the trial data showed the safety profile was entirely manageable. Yes, you have more side effects than a sugar pill, obviously.
Right, some fatigue, anemia.
Exactly, but it wasn't debilitating for the vast majority of men.
So the takeaway here is synergy.
It is. We used to worry that using both drugs now would leave us with nothing for later. But this data suggests that hitting the cancer with both mechanisms simultaneously creates a level of destruction you just don't get by sequencing them.
Blocking the hormones and blocking the DNA repair at the exact same time.
Right. It fundamentally changes the standard of care discussion for men with these BRCA or ATM mutations.
It really sounds like if you have these mutations, the kitchen sink is the way to go.
Without a doubt.
But let's look at the other side of the coin. What happens when the standard drugs stop working? We talk a lot about enzalutamide resistance.
This is the wall many patients hit. The cancer evolves, it learns to ignore the hormone blockers, it essentially rewrites its own operating system to completely bypass the drug.
Enter a new challenger, Igermetostat. Now, this works on something called epigenetics.
Correct. Igermetostat is what we call an EZH2 inhibitor.
Okay, no jargon allowed. We need to explain EZH2.
Fair enough. Think of your DNA as a massive library of books. Every cell in your body has the exact same books.
Okay, tracking.
But a heart cell only reads the heart books, and a liver cell only reads the liver books. EZH2 is the librarian. It decides which books get closed, locked, and put down in the basement.
So it controls access to the instructions?
Exactly. When prostate cancer develops resistance to drugs like enzalutamide, it uses this EZH2 librarian to lock away the genes that actually make the drug work.
Oh, wow.
Yeah, it essentially closes the door that the drug uses to enter the cell.
So the drug Igermetostat basically fires the librarian.
It forces the librarian to unlock those doors. It reverses those epigenetic changes, essentially resensitizing the cancer to the hormone therapy it learned to ignore.
It turns the resistance off.
That's the goal.
And the data from this phase 1b2 trial seems to really back that up. They took patients who had already failed on drugs like abiraterone.
So these are guys running out of options.
Right, and they gave them this new combo. The results were pretty impressive for that specific population.
They were. The median radiographic progression-free survival, so how long until the tumors physically grew on a scan, was not even reached after 13 months.
In a post-abiraterone setting, that's highly unusual, right? You'd expect the cancer to start moving again much faster.
Much faster, usually in 4 to 6 months. But here, the 12-month rate was nearly 60%.
That means 6 out of 10 men were still holding the line a year later on a drug combination that theoretically shouldn't have worked anymore.
Exactly.
And again, we have to check on the misery index. Did the new drug make the patient sick?
Surprisingly manageable. No dose-limiting toxicities were reported at all. It seems to be a very viable option for that post-abiraterone window where we often really struggle to find a good next step.
That is incredibly great news. Now, we want to shift gears entirely. Let's move from pills to particles.
The Star Wars stuff.
Yes, exactly. We're going to talk about radioligand therapy. This is the search and destroy stuff that's been getting so much attention lately.
It's really the new frontier of treatment. The basic concept is simple. You attach a radioactive isotope to a molecule that seeks out a target on the cancer cell.
Usually PSMA.
Right. And it delivers radiation directly to the tumor.
Like a guided missile. But there's a problem with the current missiles, specifically with Pluvicto or lutetium. Sometimes the target just isn't bright enough.
Exactly. PSMA isn't always there in high amounts. If the tumor doesn't express enough PSMA, the missile just can't find it.
We call these tumors dim.
Yes. And if your tumor is dim, you generally don't get the treatment.
So the UPLIFT trial, which is a great name, by the way, is a phase 1/2 trial trying to fix that. This is coming out of UCSF.
Right.
They decided if the target is too dim, let's install a spotlight.
It's a brilliant mechanistic hack. They used a drug called abemaciclib. Now, usually this is used in breast cancer. It's a CDK46 inhibitor.
Okay, hold on. Why on earth are we using a breast cancer drug in prostate cancer?
Because of what it does to the cell cycle. They found that this drug blocks a specific regulator. When you block that regulator, the prostate cancer cell gets stressed out. It panics.
And in that panic,
It starts cranking up PSMA expression.
so by stressing the cancer out, you force it to wave a giant flag saying, hey, I'm right here.
That's the perfect analogy. It effectively makes the cancer glow brighter on the PSMA of PET scans.
And the protocol is really clever. They don't just give the drug continuously, do they?
No, because continuous dosing causes too many side effects. They do a pulse.
A pulse?
Yeah, a 14-day lead-in of abemaciclib to supercharge the PSMA levels, turn on the spotlights, basically. And then, boom, they hit it with the lutetium-177 PSMA-617 radiation.
This matters so much because it opens the door for patients who were previously told, sorry, your PSMA levels are just too low for this treatment.
It turns a no into a yes.
Yeah.
It expands the eligible population significantly.
Speaking of turning things up a notch, let's talk about the PAnTHa trial. This is a phase 1 trial, and it isn't lutetium. This is actinium-225.
Right.
And I feel like we need to explain the physics here for a second.
Yeah.
What is the difference between lutetium and actinium?
It's basically the difference between a bullet and a cannonball.
Okay, I like that.
Lutetium is a beta emitter. It releases electrons. They travel a bit further, maybe a few millimeters, and cause damage. Actinium is an alpha emitter.
Meaning.
It releases helium nuclei. These are heavy. They travel a very short distance, just a few cell widths, but they cause massive, irreparable DNA damage.
So actinium kills better. But the problem has always been collateral damage.
Right, because it's so powerful. If it sticks around in healthy tissue, it destroys it. The big tissue has historically been the salivary glands.
Xerostomia, right? Dry mouth.
Yes, and I don't mean just being a little thirsty. I mean zero saliva. You can't eat dry food. You can't sleep because your throat literally sticks together. It absolutely destroys your quality of life.
So the PAnTHa trial is trying to solve the dry mouth problem with a new molecule. Actinium-225 PSMA-Trillium.
Trillium, it does sound very sci-fi.
It really does.
But the innovation is purely chemical. They added an albumin binding domain.
Which is what exactly?
Albumin is a protein in your blood. By binding to it, the drug stays in the bloodstream longer, giving it much more time to find the tumor.
Okay, that makes sense.
But, and this is the key, because it's bound to albumin, it doesn't get taken up by the salivary glands as easily, and it clears out of them much faster.
So bigger bombs, but way less friendly fire.
Exactly. And the results from the phase 1 trial are incredibly promising. 83% of men saw at least a 50% drop in their PSA.
Wow.
And 58%, so more than half, saw a 90% drop.
A PSA 90 response in a phase 1 trial for mCRPC is almost unheard of. That is incredibly potent stuff.
It confirms that alpha therapy is the future, provided we can manage the toxicity. And Trillium seems to be doing just that.
Before we leave the world of radiation, I have to quickly mention the SECURE trial. This is a phase 2 trial using copper-67.
Yes.
Why copper? We already have lutetium and actinium. What does copper bring to the table?
Copper is exciting because it offers a perfect theranostic pair. You use copper-64 to take the picture, the PE scan and copper-67 to do the killing.
I see.
Because they are chemically identical, you know exactly where the therapy will go based on the scan. There is literally no guesswork.
We actually have an update on a specific patient from this trial that I think perfectly illustrates the power here. A 76-year-old man.
Right, I read this case.
He's had cancer for 15 years. His PSA was steadily rising. He goes into the trial.
And 7 weeks later,
Undetectable.
undetectable.
His PSA went from 3.25 to absolute 0. Scans completely clean.
And this isn't a fluke. This is the 5th patient in that program to reach undetectable status.
It shows that when you can match the right isotope to the right patient, the response can be absolute.
We aren't just managing the disease anymore. In these cases, we are effectively clearing the board.
It really is the holy grail. Okay, let's pivot. We've done drugs, we've done radiation. Now let's talk about the smart bombs, immunotherapy and molecular glues.
Immunotherapy has been the really tough nut to crack in prostate cancer. It works beautifully in melanoma, lung cancer.
Prostate cancer is what we call cold.
Right, exactly. The immune system just ignores it, doesn't see it as a threat at all.
So we have to wake the immune system up. That's where VIR 5500 comes in. There's a phase 1 trial for a T-cell engager.
Right. Imagine a set of handcuffs. One side grabs the cancer cell via PSMA, and the other side grabs a T cell.
Your immune soldier.
Yes. And it forces them together. The T cell says, oh, this is an enemy, and kills it.
But the problem with these handcuffs historically has been that they activate T cells everywhere in the body, not just at the tumor.
Exactly. If you activate T cells in the blood or the lungs, you get a massive immune freakout called cytokine release syndrome, or CRS. High fevers, organ failure. It's highly dangerous.
So how is VIR 5500 different?
It's masked.
Like a sleeper agent.
That's the perfect analogy. It travels through your healthy blood vessels in a totally inactive state. The binding mechanism is completely covered up.
Okay.
It's only when it enters the tumor microenvironment, which is full of specific protease enzymes, that the mask actually gets cut off.
So it only wakes up and puts on the handcuffs when it's standing right next to the tumor.
Correct. This keeps the systemic side effects very, very low. You just don't get that massive CRS event.
And the efficacy.
In the high-dose group, 82% of patients achieved a PSA50 reduction.
That is massive for immunotherapy in this space. It's usually been a graveyard for trials. Now, what about this molecular glue?
MRT-2359.
Yes, a phase 1/2 trial. Sounds like something I'd use to fix a broken vase, not treat cancer.
The name is a little bit misleading. It's actually a degrader. Think about how enzalutamide works. It's a blocker. It sits in the androgen receptor chair, so testosterone can't sit there.
But the chair is still there in the room.
Exactly. And eventually, the cancer figures out how to sit in it anyway.
So MRT-2359 doesn't just sit in the chair.
No. It marks the chair for destruction entirely. It acts as a glue that sticks the androgen receptor to the cell's waste disposal system.
The ubiquitin proteasome system.
You got it. It basically tosses the entire receptor right into the wood chipper.
And it doesn't just stop there, does it?
No, it also degrades other bad actors like MYC and cyclin D1, which are known to drive cancer growth.
And this is specifically for guys with a certain mutation, right?
Yes, specifically AR-LBD mutations. These are mutations in the ligand binding domain.
Basically, the lock has been changed, so standard drugs don't fit anymore.
Right. And the results for those specific guys.
In the patients with those specific mutations, 100% saw their PSA drop by half. Every single one.
That is the very definition of precision medicine. You find the specific broken lock, and you bring the specific sledgehammer.
And one last smart bomb to mention is the precision platform, specifically AVA6103. This one uses FA-key fibroblast activation protein as a trigger.
Right. Tumors are surrounded by this dense scar tissue, or stroma. This stroma is absolutely full of FAP.
Okay.
This technology uses that specific enzyme to release a chemo payload exatecan right at the site.
The comparison here is against Enhertu, which is a leading antibody-drug conjugate.
And in the models, this new platform delivered 10 times higher concentration of the chemo directly into the tumor compared to Enhertu. And it got there faster.
It's all about delivering maximum damage to the bad guys while totally sparing the innocent bystanders.
Incredible innovation.
Okay, we have covered the high-tech wizardry. But now I really want to talk about something that feels a little more primitive, or maybe primal is the word.
The paradigm shifts.
Yes, we are going to look at the STAMPEDE analysis. This is a retrospective study looking back at over 2,000 men. And they ask a very simple question. Can your muscles predict your survival?
It sounds almost too simple, doesn't it? Like something a gym bro would say.
Right.
But the data is incredibly compelling. They looked at CT scans, which all these patients have anyway, and they carefully measured the skeletal muscle index, or SMI.
Basically, just how much muscle do you have on your frame?
Yeah.
What did they find?
For men with metastatic cancer, having higher muscle mass was significantly protective. For every 10-unit rise in that muscle index, the risk of death dropped by 15%.
15%. That is better efficacy than some of the drugs we spend billions of dollars developing.
It really is. And here is where it gets highly actionable. It also predicted who would actually benefit from the aggressive combination therapies we talked about earlier.
So if you have low muscle mass going into treatment,
If your muscle mass was too low a condition we call sarcopenia, the study found that adding the extra aggressive drugs like abiraterone plus enzalutamide didn't actually help you live longer.
you just got the toxicity without the survival benefit.
Exactly.
Why is that? What is the muscle actually doing?
The muscles isn't just for lifting things. It's an active metabolic organ. It acts as a massive reservoir for your body. It helps metabolize drugs, it reduces systemic inflammation, and it physically supports the body through the severe trauma of treatment.
So if you don't have that reserve, your body creates a toxicity ceiling.
Yeah.
You just can't tolerate the cure.
Exactly.
So the actionable advice here isn't just take your pills, it's hit the gym.
Within reason, yes. Resistance training. Maintaining muscle mass during hormone therapy, which naturally tries to melt your muscle away, is not just about looking good. It is a critical survival variable. It is a biological shield.
That is so empowering. It's something you can actually do today.
It completely puts some control back in your hands.
Finally, let's talk about one last concept. Evolution. This comes from the Evolutionary Oncology research. And they propose something called the double blind.
This is a concept straight from game theory, or warfare, really. You
Yeah.
force your enemy into a position where every single move is a bad move.
A true catch-22.
Exactly. So researchers found that when prostate cancer cells evolve to survive radiation, when they become radioresistant, they have to make a major trade-off.
What kind of trade-off?
To repair that severe radiation damage, they are forced to display certain flags or ligands on their surface.
And who sees those flags?
Natural killer cells. NK cells. These are a very aggressive part of your own immune system.
So if the cancer hides from the radiation, it basically reveals itself to the immune system.
And if it hides from the immune system, it becomes totally vulnerable to radiation. It literally cannot be resistant to both at the exact same time.
That is the double blind.
The proposed strategy here is a 1-2 punch. First, you hit them with radiation, not just to kill them, but to purposefully force the survivors to adapt.
You force them to put out those flags.
Right. And once they are exposing those flags,
Then you unleash the NK cells to mop up the survivors. You are literally steering the cancer's evolution right into a trap.
it's like herding them into a box canyon and waiting at the other end.
That's a really good way to visualize it. It turns the cancer's own survival instinct completely against it.
It's brilliant.
So what does this all mean? We've covered a ton of ground today, from gene editing drugs to alpha particles to literally lifting weights.
If I had to synthesize this whole deep dive, the aha moment is that we are firmly moving past the era of one-size-fits-all.
Right. We aren't just giving everyone the same hormone blocker and hoping for the best anymore.
We are getting incredibly granular. We are matching specific drugs to specific genetic breaks, like we saw in the BRCAAway trial.
We are using spotlights to boost dim targets in UPLIFT.
We are masking drugs so they only explode inside the tumor, like VIR 5500.
And we are realizing that your body, specifically your muscle, is an active partner in this fight, not just a passive vessel for the drugs.
That's the absolute key. Amidst all this incredible high-tech molecular science, the CRISPR, radioisotopes, gene editing, your own physical resilience remains a critical biological variable. The science is doing its part, the drugs are getting vastly smarter, but you have a vital role to play too.
That's a powerful message. It's a true partnership between the lab and the gym.
Ideally, yes.
You know, it makes me think about where this is all heading next. We talked about muscle mass being a predictor, but I imagine a future where trials actually require specific fitness benchmarks before you even start these intense radioligands.
Oh, absolutely.
Like prescribing a highly specific, monitored exercise regimen as an actual dose drug protocol, tracked by wearables, perfectly timed with your actinium infusion, the ultimate precision medicine combining tech and sweat.
That is exactly where the field is heading, integrating the biology of the host with the physics of the treatment.
Well, that is all the time we have for this deep dive. A lot of hope, a lot of homework, and plenty of reasons to be optimistic. Thank you for guiding us through it today.
Always a pleasure.
To our listeners, stay strong and fight on.